GP in Camden, and I was the Camden COVID hub clinical lead at the height of COVID, and I'm the clinical lead of COVID in my practice, and I'm quite involved with research at Public Health England regarding COVID in children and COVID and vaccines. And I was asked just to give an update today. I think probably what's relevant to say is that this is probably the best we've been in terms of COVID for a while now. It's been lots of ups and downs, but the landscape's always changing. And so, yeah, just bear that in mind. I'd like, before I start, to probably thank a few people for my slides. So that's Public Health England, who'd helped me with the prevalence slides, and also Dr. Melissa Heitman, who is the long COVID consultant at UCLH. Okay. So, sorry, I'll go back. I'm just going to be talking a little bit about prevalence of COVID data. We'll briefly touch on assessing COVID patients, because I think that isn't such an issue at the moment. And then we'll think about long COVID, which I think it probably is going to be something that we're all going to, as GPs, need to know about. So this is data that is released every week from Public Health England, and this is data that was released week beginning Monday, the 31st of January. So really the key messages in terms of COVID and infection levels are that really cases are stabilising, things are getting better. And so the overall positivity in Camden is about 8.7% at the moment, slightly higher than London as an average, which is 8.5%. And then when it comes to vaccine, we're still trying to push vaccine, but I think appetite is decreasing, and we'll come on to that a bit later. But certainly the key messages is really about inequalities regarding to vaccine uptake amongst ethnic groups, and the Black Caribbean population seem to be the group that are not so keen on having it disproportionately to perhaps the white population. We know now that we don't have to do a PCR test if you've got a positive lateral flow. So this is obviously going to have a huge impact in terms of levels of positivities that we've seen. We know that they're declining, and LFD lateral flow tests are rising, and they're highest in the 18 to 39 population. So if you look at this graph, you can see that really it starts in December till the 24th of January last week, and levels of testings going down massively. Overall, the pink graph there are the 18 to 39-year-olds who seem to be the age group kind of seeming to have most positive tests, and you can see that the young children is also a big peak here as well, but that seems to be declining now as well. I think it's no coincidence that the peak of the young people here is really around, or people generally, is kind of Christmas, right, and New Year. So that's something that's interesting. Really key, really, though, is that the hospital and patient numbers are stabilising, and I think this is multifactorial. Vaccines definitely likely to do that, and also possibly the fact that Omicron does seem to be more mild than Delta, which was the predominant strain up until really the first week of December. So these are numbers really in terms of uptake in Camden of vaccine. We'll break it down a bit more, but certainly overall people over 80 are being vaccinated, and the likelihood of being vaccinated kind of decreases with age. But what I think is important is that the clinically vulnerable people do have high levels overall, although I don't know if you'll know, but the actual PHE kind of target is 95%, and certainly we're not anywhere near there in London at the moment, which we'll explain as we go along. And then there's a difference in second dose and first dose of vaccine that seems to be more kind of prevalent in younger age groups than older age groups. But again, we'll break that down in a minute. So this really looks about where Camden lies in context of London as a borough. And Camden is one of the lower uptake boroughs in London. Top is Bromley, Bexley and Sutton, which are very different demographically to Camden. But actually in London as a whole, it ranges from kind of 65% to about 76%. And London is less than perhaps other boroughs in the country. But you can see here that I think there is very, very little difference between kind of the lower third boroughs, of which many are in NCL. So we've got Camden, Islington, Haringey, all here. And I think there's something about kind of affluence as well. So if you break it down into age group, you can again see that the older people are more likely to be vaccinated. This shows out the national target of 95% that we've not reached really. And then the younger people are less likely to be vaccinated, about 50% of 16 to 17-year-olds, and even less when it gets to the 12 to 15-year-old age group who are also eligible now as well. Boosters, again, even lower. Less people are up for boosters, and we're trying to understand why that might be. But certainly it might be because actually so many people have got COVID in the last, 3 months, and you can't have a booster within 4 weeks of that. And if you're a young person, it's even longer. So that's important to think about as well. Omicron is the most dominant variant in London now, and I think as of you can see in this graph, I mean the green bit here is Delta, like very little Delta, and we think that the Delta Omicron took over from about the second week of December. What's interesting is that, as you may know, Delta doesn't really give you any protection of Omicron. So there are many, many people who may have had Delta, for example, in November or even early December, and we're seeing that they're also having now Omicron. Because the Delta isn't protective. However, we do know that Omicron is protective against Delta. So we hope that this might be the beginning of a decline, because people, and so many people have had Omicron, that does give some protection. Again, the worry is always about new strains coming, and that's something that we just need to watch and wait and try and figure out and see what happens. I'm not going to really touch on this, but it's about kind of assessing patients with COVID, partly because what we're seeing now is mild COVID and significantly less hospital admissions. And if people are admitted, it tends to be those with comorbidities or other problems. But certainly what's really important is pulse oximetry and symptoms. So if they're kind of breathless, severely fatigued, silent hypoxia, those are things that you need to be thinking about, and getting people SATs probes and measuring that. This is a new scoring system that some people used a while ago to kind of score how severe someone's COVID might be. I think we're going to spend most time really talking about long COVID, because I think this is where, as GPs, we need to be thinking about and aware of, and this is one of the biggest sequelae of COVID. And certainly as practicing GPs, when patients are presenting, this is something that we need to be thinking about. So what is post-COVID? Was called long COVID, but now it's called post-COVID. And it's the definition that's been kind of come up with NICE is really about signs and symptoms that develop during or after infections consistent with COVID, continue for more than 12 weeks, and are not explained by an alternative diagnosis. So long COVID is a diagnosis of exclusion, really, really important. And in terms of people who have had an infection consistently, we don't necessarily need to be proven COVID. Lots of people got COVID. Remember, we weren't even testing really in the first wave unless you were admitted into hospital. So, if they think they've had a COVID-like illness from March 2020, however, if they said it started in 2018, for example, then I think it's less likely to be COVID. It usually presents as cluster of symptoms, often overlapping, and that can fluctuate and change over time and can affect any system in the body. And you can consider the diagnosis before 12 weeks when it's acute, when it's significant. So you've got acute COVID, which tends to happen, and people might be unwell for 4 weeks, and that would be considered quite normal. When they're 4 to 12 weeks, you can just say perhaps it's ongoing symptomatic COVID, but certainly more than 12 weeks is something that is post-COVID. And as I say, it's not explained by an alternative diagnosis. So it's a diagnosis of exclusion. How many people have it? We think about, as of December, about 1.3 million people reporting self-reported COVID, and that's really long COVID, and that's kind of more than 4 weeks. And then a smaller number, but still a significant amount, kind of more than 12 weeks, and then about 500,000 people over a year still have symptoms. Risk factors are age, so really 35 to 70, and we're seeing that the prevalence is increasing in younger age groups. Women, those who are living in deprived areas, health and social care workers, very high risk factors, teachers as well, and those with pre-existing condition. We think that maybe those that are overweight might be more high risk, and certainly maybe those who had more severe acute illness might also be high risk. But we don't actually know the exact prevalence of post-COVID syndrome in North Central London. And this is because of awareness amongst health professionals. And one of the reasons we're doing this talk, and also residents, they just think that, they're stressed, they're tired, or, other symptoms, because they can be quite vague. And then we'll go into that in a bit more detail. So really, there are multiple phenotypes for long COVID or post-COVID syndrome, and really fatigue, brain fog, chest pain, palpitations, post-exercise malaise, breathlessness, and they all kind of overlap with, other symptoms as well. But it's really, a combination of end organ damage, pre-existing comorbidities, psychological symptoms as well, which are related to stress, loss of self-image, and it's really this clustering of phenotypes as well. And it's something to be thinking about, because it's not very, very clear with one kind of symptom how people can present. And certainly we have to say that diagnosis of exclusion, because actually, people can have interstitial lung disease secondary to COVID. They can also have, some kind of neurological stuff, some autonomic symptoms. We know people lose sense of taste and smell, for example. And then there's also some morbidity around those who were admitted to ITU. And ITU admissions were an average of about 6 weeks. So, people were in hospital for a very long time who were ill and were fortunate enough to survive. We don't really understand the mechanisms of post-COVID syndrome, but we think it's certainly something to do with, obviously, the immune response, mast cell activation, stress, this kind of viral persistence, maybe a bit of autoimmune processes going in there as well with some kind of viral reactivation and end organ damage. It really is multifactorial, and I think this is the idea of this slide. Both hospitalized and non-hospitalized patients can experience severe sequelae. So, whether they've had it mild or been intubated, you can both come out with the same symptoms of post-COVID. And certainly, we've seen post-COVID in patients who were asymptomatic, so didn't necessarily even know that they'd had COVID, but then had found to have antibodies on testing. So this is a recorded prevalence in NCL. So kind of the Office of National Statistics kind of thinks that perhaps post-COVID is, rates are about 20%. Going down to Camden, the rates that we've seen are significantly lower than predicted. And if you're looking at the long COVID service, 40 Camden practices have never even referred one patient for long COVID, and that doesn't quite fit. Because if you've got 1,000 patients, 100,000 patients in a cluster, you'd be expecting to have about 66 of them having long COVID, but actually maybe less are being referred. So these are the common symptoms, really. Fatigue, breathlessness, headache, brain fog, chest pain, palpitations, myalgia. Clinical judgment's really, really key. Remember, it's a diagnosis of exclusion. So in terms of that, we need to make sure that everything's excluded. Lab confirmation of COVID isn't needed to give someone a diagnosis of post-COVID syndrome, but they should have the idea that COVID has kind of triggered their symptoms. So it's not necessarily like, as I say, being unwell from 2018. The trajectory of recovery is really important. Impact of work and life, mental well-being, really, really key. There is a self-assessment questionnaire that patients can fill in before one is referred. We appreciate that it's, people who don't speak English or perhaps aren't literate, that's not a completely prerequisite for referral, but it's helpful for the referring team to have that. It's really key not to dismiss symptoms as anxiety. This does seem to be, a real issue, and it's important to take people seriously and listen to them and think about this, particularly in those with multimorbidity, where it's a bit less obvious what could be going on. This really just tells us about the pathway for NCL for referring patients with post-COVID syndrome. And where we are concerned with primary care, we do this kind of assessment questionnaire. We make sure that we've excluded any other red flags. Really, really important, that we're not missing other important diagnoses. And then once that's done, you can then refer via the single point of access to the post-COVID team. This is just identifying a bit further about what I said. In primary care, we refer to the kind of community services and who then kind of triage patients and identify them to where they need to be. The the post-COVID syndrome team is vast. They've got a GP who's on there who kind of helps bring patients to the assessment. They also have consultants, care navigators, therapists, physios, nurses, psychologists. And I think this is really, really important to understand that it's not just doctors, it is a whole team. And certainly they have the respiratory clinicians as well, because there are other things that could be going on that could be causing it that is physical. This is just a slide from when I last did this 6 months ago about the kind of tests that they might even do once people have been referred for symptoms, and just to show that there is, pathology that's found. So, in CTPAs, they found in patients who were hospitalized, PEs, in 8.7% of them, they sometimes have been doing troponin checks and D-dimers and patients who are desaturating. And it's important to just understand that these patients, when needed, are investigated by the medical team as well, although the single point of access is initially via the MDT team. This is an example of what happens to people once they've kind of been assessed and where they might go. 50% of patients who haven't been hospitalized discharged, and actually a significant proportion might be referred to cardiology. They've got cardiac pathology, neurologists as well. Fatigue rehabilitation is a significant proportion. We'll talk about that a bit later. Breathlessness support as well, and 35% are referred to IAPT. I think that's really important to understand where these people can sometimes go. So really the management of post-COVID is really affirming the diagnosis, but making sure that there isn't anything else going on, as I said. There's no biomarker diagnostic tests for post-COVID syndrome, but it's really about having a holistic overview and understanding what's going on for these patients. Investigations are still quite unclear. Clinical judgment's really needed. And as I say, this is where the multidisciplinary team is really important, because if someone's breathless, actually sending them to a respiratory physician outside of this may not be that helpful, because actually the respiratory physicians that help within the MDT might see pattern recognition and understand quite well about things that they're seeing. This is a table that it's a bit cut off, but it basically kind of tells you what tests to consider regarding how people might present. So obviously, if they're breathlessness, you'd be doing the breathlessness scale. If they're just tired, you'd be thinking about the fatigue assessment scale. If they've got postnasal drip and cough, you'd be thinking about chest X-ray. Anxiety, PHQ-9, GAD-7. Cardiac symptoms, you would consider a Holter monitor. You might even think about BNP in the bloods. If they've got kind of P-like symptoms, you'd be thinking about, blood pressure as well. Musculoskeletal system problems, you'd be thinking about, sorry, this is chest pain, I think, particularly. You want to exclude myocarditis. Psychological causes, you want to be thinking about depression scale and the rest of it, and inflammatory causes, rheumatological stuff. So this is kind of going back towards the idea that you've got to give this as a diagnosis of exclusion first. This is just a screenshot of how one refers and where details of referral can be found on the Camden GP website. But in Camden, it goes really via e-referral to CNWL. You can do that. And as I say, you should try and do the self-questionnaire for the patients, although that's not a prerequisite for the referral being taken. So really use the EMIS template, e-referral, and make sure that red flags have been assessed properly before referral, so that we can exclude any problems. And coding is super important, because this is how we're going to pick up all of these things at the end and understand the impact of post-COVID. This is just an example of someone that might have exertional breathlessness, for example. You want to do an X-ray with them. You consider perhaps if they have chest pain as well, these basic tests of an echo and a troponin. And if all of these things are normal, you'd be thinking about perhaps if they did desaturate, you'd be thinking about a PE. If other stuff are going on, maybe you're thinking about other things like asthma. But it's just kind of understanding all the pathways need to be ticked. This is really just about talking about vaccination, and we don't really know what the impact of vaccination is on long COVID, but we think that well, we know that obviously being vaccinated reduces the risk of catching it in the first place, and so therefore if you've got reduced risk of catching it, then you'll have reduced risk of long COVID, and we know that the vaccines also reduce the impact and duration of illness as well. But overall, we don't think it completely eliminates the risk of long COVID. And again, the jury's still out. We're still collecting data about that. This is an example of the multidisciplinary post-COVID team and who they contain. Melissa Heitman, who thank you for your slides, Toby Hillman, these are the respiratory consultants, infectious disease consultants. You've got neurologists on the team, hematologists on the team, a cardiologist on the team. And as I say, they're a very, very highly skilled team. They're seeing these patients all the time. And so if you've got someone with potential post-COVID, this would be the team to refer to rather than, a cardiologist or a respiratory physician, because this is the more holistic approach, because you can see we've got radiologists, therapists and trainees all within it, and they meet weekly, and they also work within the community as well. And as I say, there is a GP on this MDT as well. Treatment for post-COVID, it's really symptom-based. Psychosocial needs are really addressed as well. And then referral onwards, you saw 35%, it's kind of fatigue management. So it's really kind of multi-modality therapy, really, with psychological support as well. This is obviously if things if physical causes are excluded. And there's a big study going on at the moment, really, about, scanning patients who have, continuous breathlessness and giving them, certain medications versus NSAIDs, etc., to understand, what works best. I thought this was really helpful, and this is quite helpful for all kind of post-viral fatigue syndrome, kind of talking to patients about pacing, and that there'll be good days and bad days, and that they really need to just pace themselves. And I quite like this spoon theory, where it's basically a creative way to explain what it's like living with a chronic illness, and also for patients to understand, why they might be tired. So if you had 12 spoons a day, how would you use them? And understanding that 4 spoons is shopping, going to doctors, and exercising, and 1 spoon is kind of getting dressed, watching TV, and just thinking about not overdoing it, and pacing yourself, and fearing, how many spoons you might have that day, and working on exercise tolerance as well. This is just a slide about self-management support, and there's lots out there for patients who might have post-COVID syndrome online, and kind of helping them. The referral waiting time is about 12 weeks at the moment, so there is a bit of time before they're seen, and so this is kind of referral ways that you can send them. Take-away messages really is that there is this pathway now for patients with post-COVID syndromes, and the waiting times are improving. Do consider long COVID in vulnerable groups, so patients who who might have underlying conditions already, who have history of depression, who are in those certain age groups. And a proactive approach can actually really contribute to improved outcomes rather than things getting worse. Self-management advice should be given really early, because as you can see, the treatment isn't necessarily a tablet, or the treatment isn't necessarily, something that is going to work immediately. It is really about working with these cohorts of patients and helping them improve their quality of life with, physio, IAPT, and other support mechanisms. And if you've got a complex case, you're welcome to join the MDTs. And as I say, the Camden lead is Dr. Stuart McKay-Thomas, who you can reach out to should you have any questions. So in conclusion, there's still a lot to be done. We need to really increase kind of community activity for it. Wider benefits for other long-term condition management as well, because we're learning a lot about how to manage patients who do suffer from long-term conditions. Stimulate is the study that I was telling you about, and hopefully once the data comes out from that, we'll have a better understanding of what the treatment options are and what works best. That's me done. I don't know if anybody has any questions, but if you do, please ask away.
Yeah, sorry, I was just, I thought you were going to say I was trying to type quickly. I just wondered, so I'm a sports and exercise medicine doctor, so we learn a lot about chronic fatigue. And to me, it seems like, and correct me if I'm wrong, but that sort of post-COVID syndrome is an arm of sort of the overriding umbrella of chronic fatigue syndrome, but it's just that a lot of people have the same underlying maybe trigger or cause, which is COVID. I don't know what your thoughts on that are, and whether it is truly a separate entity or whether it is part of this umbrella of chronic fatigue.
Yeah, I think that's very. I think it's all an umbrella. I don't think it's a clear entity at all. There definitely are people with chest pain and breathlessness who we do find have interstitial lung disease, for example, or they do have myocarditis that they need to take a dose of NSAIDs for, and actually their symptoms then do improve. Do you see what I mean? So there is that kind of clear physical impact, or who have kind of autoimmune response, and then you have those that where it's actually less clear, and I think Anna, they would be the arm where perhaps it is more of a chronic fatigue, and then you've got the ME cohort even in there as well, right, where again I think probably one could argue is also a branch. So I do think it is probably one kind of spectrum as opposed to being separate entities. I don't know if that answers your question.
Yeah, no, it does. That's really helpful.
Any other? I mean, I think what's going to be interesting that we don't know about is if Omicron has different levels of post-COVID, given that we think it's a more mild strain. I think that's going to be an interesting thing, and the jury's it's too soon for us to understand that at this stage. But the other thing I think we need, that they're really keen on, is this whole kind of thing about health inequalities that COVID has highlighted with everything, but certainly there is less, there seems to be less post-COVID in, non-white, non-English speaking populations. And there's something in there about perhaps us, them not recognizing that it's a problem and thinking that, it's all for more understanding even what it is and education. And so I think there's, something about that for GPs in making sure that there isn't kind of further health inequalities precipitated by not recognizing this in certain patient groups. Any other questions, anyone? Please feel free to ask anything about vaccines or.
Do you think we'll ever need another lockdown?
No, I don't think it's ever going to happen. No, I mean, I think what's been really clear now is the impact it's had on people, in terms of the increased rates of obesity, the increased mental health burden, the cancer diagnosis, and actually what we're finding now, and I don't know if you guys are seeing it, and as clinicians, is that there really is, it's a really interesting time now, the kind of picking up all the pieces. And the vaccines have worked, and that hospital admissions really are significantly reduced. So I would hope that the just lockdown is something that we'll just never see again. I would hope. And the other thing, of course, is the vaccines are evolving, a bit like the way we do with the flus, and I suspect that that's going to be part of our lives now. So the big question that JCVI need to answer is, when the next one will be, what it's going to look like, what the strains that might cover, and those are things I think towards autumn, or not even autumn, summer, and the next 6 months, questions that will be kind of answered about that as well. Everyone's very quiet. Naseem, what usually happens now? I
have a quick question. Sorry.
Oh yes, go for it.
Hi. So I know there isn't much data on the antivirals, but would you say those who are on the antivirals are still being seen in the long COVID clinics? Do you think it's having an effect on them in the long term or not?
Do you mean antivirals to treat COVID?
Yeah. So
I think it's way too early. I mean, certainly the numbers of people who are eligible is low, and I think it's way too early, because if you think about it, it's only been offered in the last maybe 6 weeks, and so, or in December I think we were able to give it. And so if you think about the diagnosis of post-COVID is kind of 12 weeks. Do you see what I mean? The jury will be out there. That's a really, really good question, but I think it's too early for us to comment.
Right, thank you.
Any other questions at all? No. Can I just ask, is anyone seeing any patients with COVID? I mean,
not for many.
Sorry, what was that?
I've just come from A&E, so we got the odd, odd one in A&E that was quite sick, and then a few people coming in with other things that had a swab, but much less coming through anecdotally through that I'm seeing.
Yeah. I mean, we're seeing that everywhere, and certainly through general practice, we don't, patients are often calling and they have COVID but have something else, and so they're just isolating. But do you see what I mean? They're calling about something else but just can't leave the house because they're isolating, and that's a different scenario, I think, than we've seen in the last 2 years. So yeah, it is very different, I'm finding. Okay, well, if no one's got any questions, then thank you, and I think it's been recorded anyway, but I hope you found that helpful, and if you've got any questions, please do just drop me a line. Happy to answer them.
Thank you.
Thanks, everybody.
Thanks.
Bye-bye.
Thank you. Bye.
Thanks. Bye-bye.